If you don't know which variable they are testing, you'll pick the wrong answer. In this video, we're going to go over all the depressive disorders so that you will get every question right. So we'll talk about the big one, major depressive disorder. Now, major depressive disorder requires the following symptoms. There must be either a depressed mood most of the time or a loss of interest most of the time, in addition to 4 of the SIGECAPS, which we'll talk about in a little bit. The duration must be for at least a 2-week period. Pay attention to the timelines of these depressive disorders because the test makers like to test on timelines. So at least 2 weeks, a depressed mood or a loss of interest plus the 4 SIGECAPS. Now, symptoms must cause clinically significant distress, and that is a pattern for all mental disorders. It is crucial that you rule out mania and hypomania when you're reading through the question stem, because if they've had a manic or hypomanic episode, it is not major depressive disorder. So the SIGECAPS symptoms that are needed in addition to the depressed mood or loss of interest are either insomnia or hypersomnia, sleep, loss of interest if the first symptom was depression, guilt or feelings of worthlessness, loss of energy or feeling fatigued, loss of concentration, decreased appetite or weight change, psychomotor retardation, and suicidal ideation. It's also important to know the different specifiers of major depressive disorder because you may be tested on this as well. So the first one we're going to talk about is atypical features. In atypical features, there is hypersomnia instead of insomnia. There's an increased appetite instead of a decreased appetite. There's reactive mood, which is when the mood brightens in response to positive events. And there's leaden paralysis, this feeling of legs, extremities feeling very heavy. And a key feature is hypersensitivity to interpersonal rejection. Next, we have melancholic features, which is a profound lack of pleasure. They also have the key feature of early morning awakenings. Now, psychotic features, very important. They like to test on this because it can look like some other disorders. This is when there is delusions or hallucinations present in addition to the major depressive disorder. Now, these psychotic features tend to be mood congruent. So the psychotic themes are usually consistent with depression, such as paranoia, worthlessness, guilt. The treatment for MDD with psychosis is usually a combination of an antidepressant and an antipsychotic. Sometimes it is also treated with ECT. MDD with peripartum onset is highly tested. This describes depressive episodes that occur around the time of childbirth. Now, in order to meet criteria for MDD with peripartum onset, the symptoms must have occurred either during pregnancy or within the first 4 weeks following delivery. It's very high yield to know that the number one risk factor for postpartum depression or MDD with peripartum onset is a history of depressive episodes. So if you have a patient with a history of MDD and they're pregnant, you have to keep this in mind. MDD with a seasonal pattern or seasonal affective disorder is also commonly tested. Now, it identifies a temporal relationship between a specific time of year and the onset of the major depressive episode. This frequently is observed as winter depression beginning in the fall, continuing in the winter, but it can occur at any time of year, just it has to be that time of year every year in order for it to meet criteria for seasonal affective disorder. Now, common symptoms include fatigue, carbohydrate cravings, and hypersomnia, excessive sleepiness. Treatment is going to be light therapy, phototherapy. And how light therapy works is the treatment involves exposure to specific wavelengths of light for a prescribed amount of time each day to help with the circadian rhythm. Look out for that treatment because they like to test on it. In addition to the light therapy for seasonal affective disorder, there are general first-line treatments for MDD. For pharmacotherapy, this is SSRIs and SNRIs. They are first-line treatment and they can take 4 to 6 weeks to fully work. You need to remember this because test examiners like to see if you know this, and they will test you on someone that's been taking an SSRI for about 3 weeks, and the answer should be that you continue the medication at current dose because it hasn't had long enough to work. first-line therapy is CBT. CBT is almost always the right choice on exams. ECT can be used if the patient is unresponsive to pharmacotherapy, or if they can't tolerate medications, or if they require rapid symptom reduction, which would be an immediate suicide risk, catatonia, or refusal to eat and drink in the elderly. They do like to test on elderly people that will not eat and drink, and ECT would be the answer in that case. So we talked for a long time on MDD, and you need to be able to distinguish MDD from PDD, which is persistent depressive disorder, because they will likely both be in the answer choices. So persistent depressive disorder must be a depressed mood for the majority of the time, most days, for at least 2 years. Remember, at least 2 years. That's the timeline they're looking for. The symptom count must be at least 2 of the following: poor concentration and difficulty making decisions, feelings of hopelessness, poor appetite or overeating, insomnia or hypersomnia, low energy or fatigue, and low self-esteem. We have premenstrual dysphoric disorder. And in premenstrual dysphoric disorder, the symptoms occur during the final week before the onset of menses, and they remit shortly after menses begins. Symptoms include affective lability, irritability, anger, depressed mood, anxiety, somatic symptoms, cognitive symptoms. They can get bloating, breast swelling, fatigue, appetite changes. And the treatment is SSRIs. Because a patient presents to you with a depressed mood does not mean that they have a primary depressive disorder. And that's why it's so important that we talk about other things that could be causing depressed mood. One of those is bereavement. So bereavement is a normal grief reaction. It occurs after a major loss, usually of a loved one, and is not considered a mental illness. Symptoms are usually self-limited, they last several months, and the symptoms will come in waves. They're not persistent. They may involve intense feelings, guilt, sadness, sleep appetite changes, and sometimes they'll have illusions, hallucinations of hearing, seeing the loved one, and that's totally normal. It's important to note that the patient's ability to function is generally preserved, because if it's not, it might be something else. So prolonged grief disorder is experiencing severe impairing grief. It's impairing them. And it persists for over 12 months after the death of the loved one. Now, MDD, bereavement-associated depression, occurs if an individual meets full criteria for a major depressive episode. It's no longer bereavement, then it's MDD. In the elderly, depression can look like dementia, and that's where pseudodementia comes in. So in pseudodementia, which is major depressive disorder, the onset is more acute, whereas in dementia, it's more insidious. They have awareness of the problems and depression, but not in dementia. In answering questions for depression, they might say, I don't know, but when they're pressed, they have the capacity to answer, whereas in dementia, they will guess answers, they'll confabulate. The course of pseudodementia or depression, the cognitive deficits improve with antidepressants, whereas in dementia, there's not going to be any improvement with antidepressants. Sundowning is uncommon with pseudodementia or depression, but it is very common with dementia. Just keep this in mind because you will be tested on elderly patients to know if you can tell the difference between depression presenting like dementia and actual dementia. To note that depression can be due to medical causes, so it's important to rule out medical causes or substance-induced causes before making the primary psychiatric diagnosis. Common medical causes include stroke, endocrine issues such as hypothyroidism, diabetes. Now, hypothyroidism is commonly tested as a cause of depressive symptoms, vitamin D deficiency, viral illnesses, and cancer. Substances and medications can cause depressive symptoms, and you have to rule these out before you can diagnose with a primary psychiatric diagnosis. You need to know what substances are frequently going to cause depressive symptoms, and the main one is alcohol. Alcohol is a depressant. People talk about drinking their sorrows away. No, it just makes them more sad. Antihypertensives. Beta blockers. You may get tested on this. Beta blockers can cause depressive symptoms. Corticosteroids cause all sorts of psychiatric issues. If they're taking prednisone and they start feeling depressed, it's probably the prednisone. Withdrawal from stimulants, what must go up, must go down. They're going to feel really depressed when they are withdrawing from cocaine or amphetamines. The key distinction for the test. So how do you know, is this substance-induced or is this a primary psychiatric disorder? So you're going to look for when the mood symptoms started. If they started before the substance and they're using the substance to cope, then it's probably a primary psychiatric disorder. But if they started using the substance first and then the mood symptoms started, then it's probably a substance-induced mood disorder. You're also going to see those symptoms improve as they are away from the substance. Hi, old videos. Click on the playlist on the right. Otherwise, good luck on your exam.